Hello? Okay, that's fine. So my name is Cristina Ayarza. I'm a second-year infectious disease fellow, and my topic today is going to be the Multistate Fungal Meningitis Outbreak from the New England Compound Center. I'm going to be talking a little bit about the first case that presented. We'll talk about how the CDC and the FDA managed the outbreak and what recommendations are out there right now for the patients that were exposed to this compound medication. So we're going to start first with a case. So this came out in the New England Journal of Medicine. A male in his 50s had a history of joint disease, especially lumbar back pain and joint pain. He presented to the hospital with a history of 8 days of headaches, neck pain, some nausea, feeling sick, fatigue, chills, no fevers, and poor appetite. 4 weeks before, he had injection, the last one of a series of injection epidural of methylprednisolone for his low back pain. On exam, he didn't have any fevers, and it was only significant for meningismus. The CT of the head was negative at that time. They did a lumbar puncture, and he showed he had elevated protein in 147. His glucose was 31, and he had a neutrophilic pleocytosis. His white blood cell count was 2,304. They did gram stain and cultures, and they were negative. So they thought, they were dealing with a community-acquired meningitis. They sent him home on vancomycin and ceftriaxone. He returned a week later with headaches again, more back pain, irritable, and he had some altered mental status. And his speech was a little bit slurred. They did an MRI at that time with contrast, and it revealed pile enhancement and ventriculitis. The spinal image revealed thoracic and lumbar enhancement also, and a small epidural collection in L4 to L5 of 1 centimeter. They did a lumbar puncture at the time, and it showed, again, elevated protein, low glucose. This time it was 2. And the white blood cell was still high. It was actually higher in the 4,000s. He was treated this time with vancomycin, meropenem, and levofloxacin, and he had improvement in the next 2 days. But on day 6 of admission, he had increased somnolence. He was having staring spells, and he had a transient right facial droop. So they repeated a CT of the head, which was showing mild hydrocephalus. They did an EEG at the time, which did not reveal any seizures, and the lumbar puncture was repeated. At this time, they started liposomal amphotericin as empiric treatment, and next day the cultures were positive for Aspergillus fumigatus. He was started also on voriconazole at that time. They did a CT of the sinuses and the chest to investigate why he would have Aspergillus meningitis, and those were negative. They repeated an MRI of the brain, which showed new infarcts in the midbrain and in the cerebellum. On day 11, the patient became abruptly unresponsive. He started to have seizures, and he was intubated. They repeated another CT of the head, which showed intraventricular hemorrhage involving the lateral ventricles. He had subarachnoid hemorrhage, and he had worsening hydrocephalus. At this time, they placed an EVD. They also did a cerebral angiographic imaging, which show vasospasms and focal dilation in the right superior cerebral artery, suggestive of a mycotic aneurysm. So on day 15, they repeated a brain MRI because he was not waking up, he was not responsive, and it showed additional cerebral and cerebellar infarcts. And on day 22, the patient expired. So this was the first case that someone noted that it wasn't right, so they called the health department in Tennessee, and this is what triggered the investigation for the outbreak. In September 2012, news broke that of a sweeping drug disaster in the United States. It was health authorities had linked the fungal meningitis outbreak to a contaminated steroid made by the company New England Compounding Center in Framingham, Massachusetts. So the New England Compounding Center is a practice in which licensed pharmacies can combine, mix, or alter ingredients in response to a prescription to an individual patient. So if a person needs a drug that's not made by the FDA, for example, if a drug has a dye that they're allergic to, then a compound pharmacy can do a specific drug without the dye for this patient. And that's what they're supposed to be doing, just drugs for individual patients. So they have their purpose. This company was established in 1998, and usually the state in Tennessee is the one that regulates the practice of this pharmacy, and they're not registered by the FDA, so they don't have to be watched by them. It was a violation because they were functioning more as a drug manufacturing, so they were creating multiple vials out of one prescription so they could sell more. And then they have done factory inspection, which also revealed unsanitary conditions, and this is under investigation right now, so I'm not going to go into details. And there were similar incidents reported before. This is more of a timeline of the outbreak. So the first lot that was contaminated was produced in May 21st of 2012. Then in September 18th, the first case was reported. In September 27th, 7 more patients were identified in Tennessee. All had gone to the same ambulatory center. In September 26th, the New England Compound Center voluntarily recalled all 3 implicated lots of steroid injections. In September 29, there was a similar case reported in North Carolina. October 4th, the CDC activated the Emergency Operations Center, and the FBI confirmed that the presence of fungi was evident in unopened vials from the New England Compound Center. October 6th, the New England Compound Center expanded its recall to all their products. And then in October 15th, the FDA sent a release where any injectable product produced by this company was of significant concern. And in October 18th, the CDC announced that the mold, the Xray Highland Rhostratum, has been recovered from unopened vials of the steroids. So by October 19th, this is a month later after the first case, 99% of the people that were at risk were contacted. So as of March 25th, this is the information from the CDC page, 13,534 patients were at risk. 89% had received spinal injections, 12% had received peripheral joint injections, and there were 730 cases of infection. Out of these, 236 were only meningitis, 144 had meningitis and paraspinal infections. Around 300 had paraspinal infections only, 33 had peripheral joint infections. There were 2 that had meningitis, paraspinal infection, and joint infection. 7 strokes, and there has been 51 deaths. And then the CDC has been analyzing around 1,000 specimens, and 182 have been positive for the most common fungi, the Xray Highland Rhostratum. This is a map of all the states that received any of the products from these 3 lots. So there were 23 states, and these are the states that have reported cases so far. And we talked a little bit. They're more concentrated in the area of Virginia, Tennessee, and Michigan, which they can't explain the area of Michigan. So they define either a probable case or a confirmed case. The probable case would be a person who received any of the injections that they mentioned, the number of the lots in the web page, that was produced after May 21st, 2012. And if this a probable case is a patient that was exposed to it and presented with either meningitis after a spine injection, Posterior circulation stroke should be a red flag. Osteomyelitis, abscess, or other infections of that area of unknown origin. And then osteomyelitis or worsening pain in a joint area that the person received the injection at. Usually the clinical diagnosis of meningitis is the headache, fever, stiff neck, photophobia, and the CSF should have at least more than 5 white blood cells. And it doesn't matter about the glucose or protein, it should be categorized under probable case. A confirmed case would be all of the mentioned above, plus evidence of a positive culture, histopathology, or a molecular study. This is more of how the patients were presenting initially as time went by. Initially, patients in the blue were presenting with meningitis symptoms, and then as time passed on, they've been presenting more with localized symptoms like abscess, discitis, or osteomyelitis, where the spinal injection was done. So this is just in words of the table we just saw. Some initially tested negative for sign of fungal infection, either by lumbar puncture or MRI, and then they continued to have pain when they got rechecked. They actually had evidence of infection. So if someone had a negative test, doesn't mean that they won't get it later on, and you should always be repeating the test in that case. So this is telling us that the fungal infection has a prolonged incubation period. These are a list of the specimen of fungi that they have confirmed in the CDC as of March 11th. So there has been 151 cases of Xray Rhostratum, which is the predominant one. There have been 4 cases of Aspergillus, which the index case we just presented was one of them. They've also seen Cladosporium and multiple other species, but just only report cases. The Xray Rhostratum is more of it's found in the soil and in dead plant material. It's usually a black fungi. It has melanin in it, and it usually doesn't cause infection unless it can cause like an allergic fungal sinusitis or allergic skin reaction. In immunocompromised patients, there's been report infections of more localized spread and disseminated disease. This is the CDC of the susceptibility to the antifungals on the most common pathogen, which is the Xray Rhostratum, and they don't know how to interpret it right now. There's no clear evidence, but they're saying the voriconazole and the amphotericin should be the top options, and then if they can't tolerate these two, they can try posaconazole or itraconazole. The diagnosis, so the testing method that you're using in the CDC would be electron microscopy, PCR, and sequencing of the DNA. And there's 3 labs in the CDC that are taking care of this. The mycotic disease branch is conducting tests on agents in the CSF, joint fluids, or any tissue from the patient. The infectious disease pathology branch is examining tissue from biopsy and autopsy, and the clinical and environmental microbiology branch is taking care of the compound product. They're testing those to see what they're contaminated with. Many patients affected by the outbreak have had negative microbiology studies despite evidence of disease. So not everyone is going to have a positive test, but if they have the exposure and the clinical findings, we need to treat. So the CDC has developed a PCR testing for the Xray fungi, and they're currently developing and they're using it. So this is kind of the studies they've done in the patient population in the exposure. So out of 627 samples from 413 cases, the PCR was positive for Xray in 28% of them. So, and the test also detected Cladosporium in one of the cases. So the test was more sensitive than the culture, because Out of 139 case patients who had the specimen tested for PCR and culture, 41, meaning 29%, were positive PCR, and only 19 patients, 14%, were positive for the culture. In total, 33% of the case patients had fungi detection in the specimens tested with the PCR or the culture. So again, 33% were detected at this time. There was no false positive PCR results, and then the FDA has not approved this test. It's currently under research, but they're using it on all the specimens they get. And a negative fungal PCR test will not rule out the fungal infection. This is an image of the brain. In this case, they had evidence of necrosis, vasculitis, and thrombosis. And this is more suggestive in the basilar artery infarct for fungal meningitis. In this one, this is necrosis in the basilar artery, and they also can see giant cell arteritis on the B slide. This is the fungal haifa, which are in black, and they can be seen in the silver stain on the vessels of the wall. And on the figure B, there's necrosis of the basilar artery, and then they use a special stain to see the haifa in red. So what should we be looking for? They say that 128 patients with no evidence of infection who showed up with new or worsening symptoms at or near the site of infection, 67, meaning 50% of them, had localized infection. And out of 109 patients with persistent but baseline symptoms at or near this, so persistent pain at the site, when they did an MRI, 14% had suggestive of infection and 25% had non-specific enhancement. So these are what you should expect to find. And the clinical significance of these findings were unclear, but you should always treat even if the PCRs were negative. The CDC recommendations for the patient, they recommend that anyone who received an injection near or at the site of the spine with one of these 3 implicated lots and who have symptoms should call their doctor or go to the emergency department. And this will include patients who initially received steroid injections that were evaluated and didn't have any symptoms. The recommendations for the clinician from the CDC. They recommend to reevaluate patients who have received the injection in the spine for signs and symptoms suggestive of infection in patients with any symptoms at or near the site of injections. And those not being previously evaluated should be evaluated at the time. And those who have already had prior negative evaluation but have symptoms should be reevaluated. They should consider an MRI with contrast if they have local symptoms, persistent but baseline symptoms, and they should always have a low threshold to repeat the imaging. You should always review the MRI with a neuroradiologist because a regular radiologist may miss the findings. Right now, they're recommending for treatment. For the first choice would be voriconazole, 6 milligrams per kilogram every 12 hours. And we should always check the trough level on the 5th day, and they said the goal level would be 2 to 5 micrograms per milliliters. To avoid levels more than 5 micrograms per milliliters because they increase the risk of neurotoxicities. They said to check levels every week, at least for the first 6 weeks of treatment, and then on any change of dose. They recommend to start treatment IV, especially if the symptoms are severe or they have a lot of complications, and then you can transition to PO once they get better. In some cases, maybe treated initially with PO, but that would be to the discretion of the physician and if they have very mild symptoms. Some of the adverse effects of voriconazole that we should remember: hepatic toxicity, which we see a lot, elevation of the LFTs, neurotoxicity, visual hallucination, which will respond to the reduction of the dose, Sometimes they have foggy feeling, unable to make decisions, forgetfulness, and this is not related to the dosing. They may have nausea, fatigue, chapped lips, alopecia, sun sensitivity, and periostitis, which is bone pain with elevated alkaline phosphatase. If you cannot use voriconazole, or if it's not responding to voriconazole, the next option would be liposomal amphotericin B. They recommend a dose of 5 milligrams per kilograms IV daily. And in severe cases, when non-responding or if voriconazole is contraindicated, you can use it. If there is still not responding, then you can use a higher dose of 7.5 milligrams per kilograms. And intrathecal amphotericin B is not recommended at this time. And then they really emphasize on continuing these drugs because they have the best outcome right now from the pharmacokinetics that they know. So if you get any side effects, they encourage you to try to deal with them before changing them to other options. The other alternatives they give you is posaconazole or itraconazole, but again, they have variable pharmacokinetics and within the CNS, and the effectiveness is not established. And they should always be making this decision with an infectious disease specialist. They can always consult with the CDC. They have in their webpage multiple numbers that they are available, and they are available 24/7. The duration of therapy, they say for CNS infections we're discussing right now, at least 3 months if they only have meningitis and they got improvement quite fast with treatment. And then they say if they have severe CNS symptoms, if they're immunocompromised, if they had strokes or persistent abnormalities in their CSF, then we have to treat for longer, 6 months to a year. And they should always have close monitoring after discontinuing the medication, and very low threshold to repeat testing and restart therapy. For the joint infections, if they're a joint in the spine, osteomyelitis, discitis, it'll be treated the same as we just discussed. When the spine is not involved, we can use a lower dose of voriconazole. So we can do 4 milligrams per kilogram Q12 hours after loading it with 2 doses of 6 milligrams per kilogram. And then we can use additional amphotericin B for severe cases, IV. And we should always involve either the neurosurgeons or the orthopedic surgeons in case we would need arthroscopy with joint lavage and debridement, because fungal infections are very difficult in those joint spaces. The duration of treatment, it would be at least 3 months, and if there's bone infection or they're immunosuppressed, it would be longer. The CDC does not recommend antifungal therapy for people who receive the contaminated steroid injections but do not have any symptoms and do not have any laboratory evidence of infection. Right now, other things that are going on after this outbreak came out from other products of the New England Compound Center. So the FDA learned that 2 patients may have infections associated to other products from this company. So they are issuing new guidance, and they're working on it. They haven't put on their webpage yet what the guidelines would be. But they're concerned about an ophthalmic drug that it's either injectable or used during eye surgery, and a cardioplegic solution, which they used during heart transplant, that was produced after May 21st, 2012. Currently, 1 patient is under investigation for possible meningitis, which could have been caused by an epidural injection with triamcinolone. So they're also investigating that. And then there's a heart transplant patient who has an Aspergillus fumigatus infection, who had a cardioplegic solution produced from the same company. So they're investigating that, but they think in the heart transplant patient that it could be other things. They don't find the connection yet. So these are other adverse events associated to compound medications. So there was also in August 2011, the FDA alerted the healthcare professionals that repackaging injection of Avastin had caused serious eye infections in the area of Miami. So there were 12 patients that were infected, and a lot of them lost their vision. So this is not the first time we see an outbreak. This is just the largest outbreak that we've seen so far. Also in November 2011 to April 2012, there were also 7 states that did 33 eye surgery who suffered a rare fungal eye infection, and this was tied to an injectable drug product made in a compounding pharmacy in Ocala. And again, most of these patients suffer partial or severe vision loss.